I'm going to talk about kinase inhibition, and I'm going to do it probably a little bit differently than what most kinase inhibition talks have come your way in the last couple of years. Okay, so we're going to talk about the biology of kinase targeting. We're going to talk about the current and likely future application of JAK inhibitors. And then if we can, I know it's a 20-minute window. If we can, I'd like to take on this fascinating area about hematoprogenitor cells. So I'm going to start off with a case. 80-year-old man with increasing lymphocyte counts for 10 years, 2010. He had a white count of 290,000, all lymphocytes. He was anemic, low platelet count. Given bendamustine plus rituximab, and they normalized his counts. 3 years later, it all came back. He got repeat treatment, and he only lasted for 1 year. So he's now started on a Brutonib with normalization on BID dosing. So he's 2 years later, he's completely in remission. So what's a Brutonib? For those of you who have not know about this is Brutonib was the choice that Human Genome Sciences decided not to go with. They decided to go with belimumab, and you can decide whether you think that was wise or not. Brutonib is a Bruton's tyrosine kinase inhibitor. It binds covalently, so once it's exposed, it's that enzyme, it binds in the binding site, that enzyme is inhibited. The Bruton's tyrosine kinase is a key signaling molecule for the B cell receptor, and if you lack this gene, or you have this gene mutated, you get X-linked A-gamma globulinemia. Basically, you have IgMs, but no IgGs. And you've arrested your B cells at the pre-B cell stage. Just to remind everybody, the pre-B cell stage, B cell biology is shown on the far from left to right. The plasma cell and memory B cell are shown on the far right. You can see a nice blue, sort of turquoise BTK underneath the B cell receptor or surface immunoglobulin molecule, and that's at the pre-B cell stage. And if that enzyme is missing, that kinase is missing, you do not get past that pre-B cell stage. So you don't generate an immature B cell that goes out into the blood. You have no B cells. You have no functional B cells. So how are we using a Brutonib? Well, Brutonib is making a big splash. I don't know if anybody is familiar with it, but in previously treated refractory CLL, compared to other alternative treatments, it had a 79% remission-free survival at 24 months. At 18 months versus 24%. In Waldenstrom's macroglobulinemia, remember this is a disease that's associated with mutations in MyD88 and CXCR4. It leads to very high levels of IgM. Ibrutinib is monotherapy, 90.5% response rate, with the median IgM declining from 3520, which is 10 times the upper limits of normal in humans, down to 880. It's also been a great treatment for mantle zone lymphoma. Mantle zone lymphoma is one of those lymphomas that does not respond very well to any other therapy, and it's associated with a very poor prognosis, and you can see the progression-free survival. Now, why am I talking about this? Well, I'm talking about this because everything that I could say about ibrutinib has application to the possible treatment in rheumatoid arthritis or rheumatologic disease. On the left-hand side, you have the B cell receptor signaling through the BTK kinase, and ibrutinib might block that excessive phosphorylation that's occurring. Ibrutinib might also block the ability of the B cell to serve as an antigen-presenting cell, which does so by capturing antigen with its surface immunoglobulin molecule and internalizing it, and then that tells the B cell to upregulate its co-stimulatory molecules. So in rheumatoid arthritis, you could imagine that this would a BTK inhibitor would have an incredible effect on the ability of all antigen-induced proliferation, so B cell numbers, whether it's in a joint, whether it's in the lung. Remember, interstitial lung disease is just loaded with B cells in rheumatoid arthritis and other diseases. It's also possibly going to affect the ability of B cells to present antigen. And remember, B cells are the major antigen-presenting cell for recall antigens in the body. So basically, you can shut down all antigen presentation. Dr. Calabrese talked about the importance of the dendritic cell for initiating antigen presentation, but all memory responses, remember, come from the B cell. Ibrutinib binds in a covalent way. I talked a little bit about this. It binds and it's stuck there. Now, this is just a little history of covalent inhibitors, and I just want you to see ibrutinib is the last in a long, great line of inhibitors, starting with aspirin and penicillin. I forgot that penicillin is an irreversible covalent inhibitor, as is omeprazole, as is clopidogrel. Now, in rheumatic disease, this is how many drugs are in clinical trial for rheumatoid arthritis, lupus, and other things. And you can see that there are many, including ibrutinib, and they're all either preclinical or early phase 2A. I've been trying to get participants in some of these trials, and some of these trials, you hear about them and then they reconsider about doing them. I think there's some challenges making these drugs. Ibrutinib, however, has been out on the market and has been very effective so far, and not with much of a safety signal that I can tell. So we've got, what are the things we have about this? Well, one, it has the capacity to induce B-cell depletion, but induce B-cell depletion by giving you a pill, right? It's not giving you IV anti-CD20 antibody that has a half-life of 6 months in your body, right? Or 21 days for every, and so forth. It also has the ability, without depleting B cells, to screw up antigen presentation and receptor signaling. So you don't even have to get rid of the B cells. You have a B cell that's just functionally impaired. And I also think, I just allude to this rheostat functionality. You have a dosing, because you have a dosing ability that you don't have with, we really don't have with rituximab. And so this is making up this oral anti-CD20 argument. You titrate the clinical outcomes. You can bake back independent of B cell counts. And they also, if you use it's reversible. It's not as reversible if you have a covalent inhibitor. You have to make a whole new B cell. But with the reversible inhibitors, you could imagine it would be very easy to titrate to a functional effect. I put down ANCA-associated vasculitis, rheumatoid arthritis, and lupus as possible, and those are, of course, the obvious places. Lupus is the one I think that's many people are paying attention to. What would be fascinating, again, like I said from this morning, the biologic effect of using these agents are so specific in a clinical trial, this can be highly informative about the biology and the pathobiology that we're going to deal with. But this is going to be part of our future. Okay. So the next case I'm going to sort of talk about this is a patient of mine who I saw in 2012 after he presented with nausea and abdominal pain. And a CT scan showed diffuse retroperitoneal infiltration of the retroperitoneal space and thoracic aorta to pelvis with perinephric involvement. He had a SED rate, CRP of 250 milligrams per liter. I'm going to show you some pictures. You can see the aorta right here, and you can see the space encasing the aorta. On the next slide, it'll be a little bit more obvious. You can see the posterior part of the aorta is actually pushed forward by this mass, and this mass goes all the way down here into the pelvis. And you can see that he's got it encasing his kidneys, okay? PET CT showed increased osseous uptake in the distal thighs, forearms, clavicles, humeri, perinasal sinuses, and he got needled by a radiologist. Any idea what the diagnosis was? Erdheim-Chester. His IgG4 was normal. He was put on anakinra. And he's been on anakinra for 5 years. I tried going to every other day dosing, and his CRP in 2 weeks went from 0.5 to 50. And we went back and looked after this paper came out. We analyzed the surgical biopsy, and the surgical biopsy shows that he's positive for the B-Raf mutation V600E, which, as some of you know, is a mutation that's associated with melanoma, right? So what's interesting about what I'm actually going to try to, again, I'm taking a free swing at the apple that Dr. Calabrese gave me, and I really want you to think about mutations. And what's interesting is that in patients with Erdheim-Chester, the most common mutation is the B-Raf mutation, the exact same mutation that occurs in melanoma. But in melanoma, it occurs on a melanocyte background, or a cell that's committed to becoming a melanocyte. There's some other mutations that show up, but it's also not in every cell in the body. It's only in the cells that make up the tumor. If you draw blood and look in the monocytes or the macrophages or myeloid cells, they don't have the mutation. So it's a very specific mutation that occurs at one point in time that lets you treat this patient. Now, these patients can be treated with a B-Raf inhibitor because this B-Raf gene is mutated. And in the spirit of talking about kinases, here's a kinase that's a B-Raf kinase is overactive. If you make a drug that binds to the B-Raf kinase pocket, vemurafenib, you can block it. If you make a kinase inhibitor, cometinib, which blocks downstream of the B-Raf inhibitor, you can also treat the Erdheim-Chester. By the way, all of these treatments are also very effective for melanoma. So what I'm telling you, same kinase cascade, two different tissues, two totally different diseases. And one point about Erdheim-Chester, it'll kill you, but it's not going to be metastatic melanoma. Okay. So what I've tried to set up for you is, as we move into JAKs, is that remember that kinases, what context they are, what stage of development the cell they're occurring in, have very different roles. And this gets even more compounded by the fact that look at the signaling cascades that we know for the JAK kinases, for the common gamma chain, alpha interferon, gamma interferon, IL-12, et cetera, et cetera. There's JAK1, JAK3, there's heterodimers, there's homodimers. They can occur in any cell in the body. It might differ in one cell as a function of how differentiated that cell is to what pathway. So just to remind everybody, JAK1, JAK2, and TYK2 are shown, you probably can't read it at the bottom, those are tissues that express those genes at the level of messenger RNA. So they are ubiquitous. They are everywhere. So when you give your JAK1 inhibitor, your JAK2 inhibitor, your TYK2 inhibitor, you're hitting kinases all over the body. You have no idea which kinase, whatever effect or biology you see, you have no idea if it's occurring, where it's occurring. You might have a toxicity that occurs in cell A and an efficacy signal that occurs in cell B. You just don't know. JAK3, a little bit better, is restricted to lymphocytes and lung, okay? So it's, again, very interesting. And the trouble with all these kinase inhibitors, as we all know, get to the point, is cut to the chase, is that all the kinase inhibitors, no matter where they seem to work on this cascade, whether they're JAK1 specific, JAK2 specific, JAK1 and JAK3, JAK2 and JAK1, they all seem to have the same outcomes, and we don't quite understand why. So I put up there is JAK3 targeting possible, will the effect be restricted to tissues? We don't know. There's a JAK3 covalent inhibitor that's being tried and explored, and we'll just have to wait and see what that shows. Okay, I just want to remind everybody, I don't have to tell you, that JAK1, JAK3 is inhibited by TOFA, baricitinib inhibits JAK1 and JAK2, filgotinib is JAK1 specific, ABT494, also known as upadacitinib, is JAK1 specific. And what do we know about the following? In phase 3 clinical trials, TOFA is effective in ulcerative colitis, and the advisory board just approved it. It's also effective in psoriatic arthritis. It's already been approved. We know about its efficacy in rheumatoid arthritis. Filgotinib has been effective in these. I wonder about the oral use is whether ever can be eclipsed by topical therapy for alopecia areata and atopy or eczema. That would be a very interesting idea. And the other thing, Matt, I'm not showing you a lot of clinical trial data because I didn't think that would be the best use of this, but the application for induction therapy is one of the things about the JAK inhibitors is they work fast. They work fast. And what's extraordinary, no matter which JAK inhibitor you use, they work fast. And in the inflammatory bowel disease world, they hate the idea of steroids. That's associated with bowel perforations and toxicity. And so now there are clinical trials where they're using JAK inhibitors like TOFA at much higher doses as induction therapy to avoid the use of steroids completely. So when you give a JAK inhibitor, how does it work in rheumatoid arthritis? Where are they working? Well, the only data that's ever been shown with the JAK inhibitors to correlate with response in clinical in rheumatoid arthritis is a synovial biopsy study done by David Boyle and Gary Firestein, where they showed that the change in delta stat and phosphostat 3, the change in phosphostat 1, paralleled the change in the DAS28 response. And so what you see is that the higher your stat phosphorylation, the more you drop, the lower your stat phosphorylation and follow-up, the bigger the change in your DAS28. So if you say that, you're looking on this pathway for STAT1 and STAT3, which are orange and black, looking for what signaling pathways. Does that help inform you? I don't think it does. We don't know which one of these pathways and in which cell type this is affecting. So the last thing I'm going to put up there with you to think about this is baricitinib in their last integrated safety analysis reported the increased frequency of DVT and pulmonary embolism. And again, this is an interesting idea. Is this bad luck? Is this a drug working at a different place, maybe like working at an endothelial cell or a platelet? But what they saw was that baricitinib increased incidence relative to the placebo control and the washout in the placebo control phases. And that incidence was maintained over time. And we'll see if that's continued with more larger and better analysis. Upadacitinib had exactly the same thing. In the face of phase 3 data was presented at the ACR, had incredible activity in a very bad patient population with 43% and 42% low disease activity in rheumatoid arthritis patients. But they also had 6 cases of venous thromboembolism. Filgotinib, another JAK1 inhibitor, just like upadacitinib, does not have this signal. And so what I want to leave you with, and as I wrap this up, because I'm not going to have a chance to go on to the end, is that I want you to think about JAK inhibition in a different way, but this is an example to help you remember how different JAK inhibition is. Here's one mutation, JAK2, in JAK2 V617F, and it gives rise to 3 different diseases. And the fact is, it's probably the stage of myeloid hematopoietic cell differentiation that determines whether it gives rise to essential thrombocythemia, P. vera, or myelofibrosis. But it doesn't really matter because a JAK inhibitor, in this case, ruxolitinib, is very, very, very effective. And as you can see, it takes down the platelet counts and and induces a response or remission in P. vera. So I think I'm going to stop there. Okay, good. Thank you.